Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric Kelly. Today I am with Dr. Winston de Mello. Winston is one of the founders of the college. He was one of the four that started, and he is a pain specialist. Good morning, Winston. How are things?
Very well. I'm glad to be on this podcast.
You've talked about pain before, and today we're going to revisit pain and have an update of pain. So what's changed lately in the definition of pain?
Well, it's very difficult to define what pain is because it's very much an individual experience. But if you go to the ISP definition from 1979, it defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. That was the original definition. Raj and colleagues in 2020 then redefined it, and it's just a couple of nuances of a couple of words. They defined it as an unpleasant sensory and emotional experience associated with or resembling. So they've changed the potential to resembling that associated with actual or potential tissue damage. And that becomes obvious when we talk later on in this podcast, the taxonomy of pain.
So there are a whole bunch of different ways of classifying pain, calling pain, and labeling pain. What's the latest update on that?
Okay, so the question is, why did they redefine it in 2020? And the reason for this is sixfold. First, Pain is always a personal experience, and it's influenced to a varying degree by biological, psychological, and social factors. So that really forms the basis of the biopsychosocial model. Second, pain and nociception are really two different things. You cannot just infer that pain is occurring just because the sensory nerves are activated. So the difference between pain and nociception is the sort of final assessment by the brain or the higher centers to convert a sensory input into that huge, complex biopsychosocial pain experience. Thirdly, throughout your life, you learn the concept of pain. You know what is good, what is bad, what is potentially dangerous, and what makes things better, like rubbing an area of the body that just been struck. Fourthly, every person's report of an experience as a pain problem should be respected. In other words, if you're assessing a child, you're assessing a geriatric patient with dementia, they may not be able to verbalize or explain what is going on. So the default position is moved to the assessor in taking perhaps a more broader, holistic approach to the pain report from the patient. Fifth, although pain serves as an adaptive role, it has a huge impact on social function and psychological well-being. And I think this is where acute pain, people who work in the acute pain world need to sort of realize that what happens acutely has massive effect on function, social, and psychological well-being. And then the final reason is the verbal description is only one of several behaviors to express the patient's pain. So the inability to communicate does not mean that the patient is not or is experiencing pain. So you need to look at surrogate evidence of pain. And for those of us who've worked on our own, it is obvious that surrogate measures like the vital signs and behavior might be a secondary indicator of being in pain.
So there's a profound difference in childhood experiences in pain and adult experiences in pain. Is there a link between childhood experiences and compared to adult, and how is that defined by the World Health Organization?
Well, this was a very interesting discovery on my part. I only discovered this very late in my career. But the WHO published a paper on adverse childhood experiences, and we call them ACEs for short. And what they discovered was from the time you're born, you discover you experience various experiences, some of which are very adverse. But what they were more concerned about was that these experiences involve social, emotional, and cognitive impairment, adoption of health risk behaviors like alcohol, drug taking, a higher propensity for disease, disability, and social problems and socialization. And what was really sad was the predictor that if you had several of these ACEs, at least 4 of these ACEs, you died early. So the morbidity and mortality to a patient along their journey, if they are in pain, ACEs complicate things. So you've got to be aware as to the background of the patient, what is going on in the life of their patient, to be able to individualize a individual therapy or tailor-made therapy for that individual patient. For example, if you're a football player and if you have an ankle injury, that ankle injury may not be a big injury in terms of the surgical impact, but it may have a huge impact on the future employment of the patient as a footballer, and perhaps worries about what this injury means to them. So it's the meaning of the pain that dictates the impact it has on the total pain experience, which is really what we refer to as the biopsychosocial and even sometimes spiritual phenomenon.
So, as paramedics, we try to assess pain from our casualty, and other than having a verbal 1 to 10, that we use the VAS, Visual Acuity Score. Is that too simplistic for us? Do we need to dive deeper into assessing pain?
Well, I think for an acute pain situation, I think it serves a purpose of trying to quantify what is a subjective experience in terms of an objective numeral or verbal score. So I think in the short term, for an acute pain problem, there will be an obvious tissue injury. It may be mild to severe. The intensity is usually related to the injury. There's a predictable trajectory for where the pain journey is going to go. And majority of the time, the treatments are usually effective. So that's the good side. But you're also going to meet patients who've got a chronic pain background, who've now got an acute episode, either related to the chronic pain background or a new acute pain problem. And I think that's where the challenge comes. And that is why I think it is important when you're taking a history from a patient acutely, you also inquire about the previous medical history, which includes the previous pain history. So in other words, have they had previous back pain or headaches or joint pains, or just a simple question, have you suffered from pain anywhere in your body on a regular basis or irregular or intermittent basis over the last few years? So that will flush out or what is going on, because that will lead to, again, being aware along that patient's journey, you're meeting them, and maybe then you can triage these patients into discharge or perhaps a follow-up by the general practitioner or family doctor, or even on rarer cases into secondary care. So I do think you should be aware that all acute pain is not just acute on its own. It could be an acute exacerbation of a chronic pain problem, or even worse, it could be part of a more complex problem. So the chronic pain is where there is no obvious pathology, usually severe, intensity unrelated to injury, unpredictable trajectory, huge impact on sleep and function, difficult to treat, and it just destroys the patient. Now, we all can see that when we deal with these patients, but we don't actually document it. So I think my practical point is, yes, sure, treat the acute phase as we've done before. using the VAS, for example, in a 0 to 10 or 0 to 100 scoring system, but also be aware of other psychosocial economic factors that are around. And our paramedics are unlikely to meet complex patients because these are usually heartsick patients which tend to rotate around different specialists, with ever lengthening of notes, poor therapeutic relationships, and actually no collaboration between the patient and the practitioner. So I think as long as one is aware that acute pain is just the more easy bit of the pain spectrum, I think then you're doing your patient a great service.
That's a good statement. And as paramedics, we're good at acute pain. We're not very good at chronic pain. And we always ask our patients past medical history. I never thought to ask what was their pain score on their past pain. That's a really good point, Winston.
And I think, Aebhric, you're right. Now that you've realized that, you were probably doing it, but you weren't specific enough to sort of say, do you have any past pain problems? So it's not just the past medical history. I want our practitioners to go more specifically onto the pain previous history and document it, because then you can see the background pain and then the breakthrough pain, just like we do for cancer.
That's quite interesting. And with pain, we as paramedics, we focus on the red flags of the patient. What kind of red flags were we looking for? Are there any other options for us?
Yeah, I mean, I think we all have this fear of missing a red flag. A red flag is an indication of a severe medical problem. Things we're thinking about is things like infections, sepsis, cancer, autoimmune disease, etc., etc. And that is where the biomedical model focuses on. We dread missing a red flag, because that's the way we are trained. And it's almost induces us to practice defensive medicine. But besides the red flags, there are 4 other flags which have been based on treatment of chronic back pain. And I think this is a good checklist if you meet a patient and if you're the isolated practitioner, and they've got a pain problem which you think is acute, or perhaps recurrent, or even worse, a chronic problem, and they're not getting better despite your interventions, then think about the 4 other colored flags. So yellow flags are basically things due to psychological factors, not being able to cope, quite isolated, no social interactions, loneliness, etc., etc. So yellow flags are psychosocial factors. Blue flags is work issues. So are they working for an organization that is not very good, like say perhaps in the mining industry or in a farming situation where the money is not good, the prospects of work and security of work not good, the pay is poor, there is no healthcare, there is no PPE, etc., etc. And then the black flags is basically things to cover things like the potential for litigation, compensation. So yeah, I got a cement burn injury whilst working on the building site. I want some money. Now, patients don't say that, but you intuitively know that that is what they're trying to achieve. And the final 4th flag is orange flags, which is basically psychiatric illness. And what that means is that if you've got a patient with a comorbidity of a psychiatric illness, that patient is going to be tougher to manage than one without. So in terms of back pain, which is where this whole concept of obstacles to recovery rose, it was pointed out that you must exclude your red flags, which is the disease process, yellow flags, which is psychosocial problems, blue flags, which is basically your work issues, your black flags, which is litigation and money issues, and orange flags, which is your psychiatric issues. So that's a quick check of what is going on in your patient's life to prevent them from recovering. And the point I'm trying to make is that quite often, if you dig deeper into these patients, you'll come across huge things. Let me give you an example of a 45-year-old ex-warrant officer who set himself on fire and was on the burns unit in my hospital. And when I saw him in the pain clinic some months after the burn, I looked at the different flags. For the red flags, he was physically unfit, poorly nutritional status, drug and alcohol abuse. In terms of his yellow factors, he had poor scoping skills, he had a poor social support, he was homeless, he was in the process of divorce and depending on his daughter. In terms of the blue flags, he was dependent on social security, he was not earning anything. And in terms of black flags, he was not employed and he was unemployable. And in terms of the orange flags, he had severe psychiatric comorbidity, deliberate self-harm, suicide attempt, body image problems, spiritually distressed. That is just one patient.
Wow.
So I think if you've got time, I'm not talking about you do this for every acute pain problem. No, for God's sake, no. I'm talking about the more complex patient. Just ask yourself a question. Has this patient got any other flags? And if so, refer them to the appropriate specialist who can help them. You can't help them. You can't help them with a job. You can't help them with money. You can't help them with psychiatric illness unless it's pretty obvious. And you can't offer them anything than basic psychological care. So I think it's a good triage tool. It helps you identify. It also reduces your frustration at not being able to help these patients.
Right. That's helpful. So medically, we look at red flags and we need to realize that there's 4 other colors that can help us with the pain patient.
Correct.
So Winston, let's talk about opioids a bit. So it was big in pain, like, yes, let's use that a lot. And then suddenly it turned into no one's using them. And the pendulum keeps going back and forth. Where are we at the moment with opioids?
Okay, so just before I answer that question, Aebhric, I need to go back in history to, say, the 1990s. In the 1990s, pharmaceutical companies were chasing each other, trying to develop new opioids to replace morphine. And then we had the semi-synthetic ones like oxycodone, or the synthetic ones like fentanyl and its other related compounds. And the whole emphasis was a translation from cancer medicine into pain medicine. And the argument was, why should somebody be in pain? Let's give them the proper medication. And if it's severe pain, let's give them an opioid. And that was good. Everybody felt better. There was a very famous palliative care cancer specialist called Portnoy from New York, who represented the medical world and sort of saying nobody should be in pain, and therefore let's have a liberal use of opioids. 2 things happened. The first thing is the proliferation of prescriptions for opioids. Thanks to that, the pharmaceutical companies made a lot of money, and they generated CPD points, really trying to sell their drugs. So it became a very sort of rapid increase in the use of opioids. We then became aware that there were problems of drug diversion, drug dependency, drug addiction, criminality, but there were more sinister ones, just like the impact of chronic opioid therapy on your mental state, chronic opioid therapy on testosterone production. So in a male who is chronically opioid dependent, the testosterone shuts down and the actual testicle shrinks. So you lose your testosterone cover. And when you know that testosterone has an impact on nearly every cell in the body, let alone your cardiac muscle, your bone, your cognitive functioning, etc., we then began to realize that there was a problem. And this included immune suppression. We think about constipation, we think about all those kind of things, but actually immunosuppression is a big price to pay for somebody who's on a chronic opioid therapy. So the evidence has gone against opioids, and we're continuously looking for non-opioid interventions, like mindfulness, like CBT, just being nice to the patient, just talking therapies, for example. So that is why the pendulum has swung the wrong, I say the opposite way, not the wrong way, but I still don't think we have appreciated where that pendulum spectrum is going to swing, either for or against opioids. So I think the jury is out at the moment.
So let's talk about non-drug choices. You just mentioned that. Can you dive a little deeper into those options?
Yeah, sure. Well, one of the most important non-drug choices is the practitioner explaining, reassuring the patient in an acute pain situation. More other therapies that include relaxation or hypnosis, imagery, for example. Children having burn dressing changes usually are managed by imagery or by distraction. Importance of biofeedback. We know that cling film applied longitudinally to a burn wound reduces the allodynia from a burn injury. The use of mirrors for phantom limb sensation and phantom limb pains is another one. You've got TENS, you've got cold, you've got acupuncture, you've got high fidelity ultrasound, physiotherapy, massage, the application of heat and cold. Mindfulness is now the number one treatment for chronic pain.
Wow.
And if you think about it, what it does is, if you think about the pain pathways, you've got a pain coming from the injured area through the nerve into spinal cord, up the spinal thalamic tract to the thalamus, and then projects to the somatosensory cortex that tells you the pain's coming from your big toe. But from the thalamus, there's also a connection with the reticular activating system, and that sets off the autonomic nervous system, usually the sympathetic, and the endocrine system. So you've got the quick response of the nervous system, and particularly the autonomic sympathetic part of it, and then you've got the slower bit, which is the endocrine system. Those two systems contribute to stress, and if that stress is chronic, that leads to ACEs in children, and that leads to poor outcome as they get older. So it's a great interlink or web between what happens to a patient, the psychological, physiological, and the pathophysiological impact of being in pain. And then there's one more that really tickled me. Being a Catholic, there was an Italian study that threw Catholic patients and asked them to pray and meditate, and whilst they were undergoing an MRI scan, and those that practice it could actually suppress the pain imaging compared to those who don't. So I think besides your drugs, your non-drug choices, and I've listed explanation reassurance as my number one, you can do a lot for your patient, even if for those few seconds that you may be in contact with them. Just explaining, I'm sending you to hospital because of this. Because you've got such a big burn, we need to do this. So it is actually stating the obvious, but in terms that the patient understands that that may contribute to the analgesic effect. And the other thing is, if you're a nice practitioner, empathetic, that has a good relationship with your patient, you can then use the placebo response, which has got no side effects, to try and calm the pain impact without drugs. And if you think about it, the placebo response can be about a 30% reduction in pain scores. So that's even before you start. you can actually reduce it by just being a good, empathetic practitioner who uses the placebo response by giving confident information. You've got this, I'm going to do this, and this is why I'm doing this, and this is what's going to happen, and you are going to get better. I'm going to take good care of you. That is just as effective as anything else.
We should teach this more. This should be higher up in the learning for paramedics and remote medics, because it's such an easy thing to use.
Yeah, I think it's the experienced ones who'll probably appreciate it more, because I think the more junior ones are more orientated on red flags.
And of course, we just throw ketamine at pain and not look at the red flags, look at the five different colors of flags, and we don't look at possibly a non-drug choice, especially in austere environments. We don't have that many vials of ketamine or midazolam, and maybe our first rung of the ladder should be a non-drug choice for pain management. Thank you, Winston, for another podcast, and I look forward to seeing you again.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.